to keep it short and simple. This is something which comes back every so often, like a bad smell, I think, hybrid surgery. And probably I'm responsible to a certain extent. This is how everything started. In the middle 90s, we started toying with the idea of doing a left internal mammary into an LAD through a small anterior thoracotomy. But of course, it was limited by the fact you could only do one graft. So in 1996, we went into the cath lab. If we were to do it now, probably we would be arrested. As you can see, the cath lab, it was a pretty primitive environment. And we said, okay, let's do the surgery first. And this is the left internal mammary, which is, believe it or not, is being lengthened with an inferior epigastric. Most of you have probably never even seen an inferior epigastric, into a block LAD. The reason being there was no way to mobilize the mammary properly. So all we would mobilize was like an inch. The whole thing wouldn't reach, and we had to lengthen it with something. And immediately after, an angiogram was done, and as you can see, there is still the radiopaque of the swab, which the wound was still open just in case we got it wrong. But in this case, was working okay. So the next thing, straight away, one of the cardiology went to angioplasty, this beautiful circumflex, put a nice stent, and everything worked. We did a whole series of these, some straight away, straightforward, some with problem, including the fact that after this bare metal stent, this is middle 90, the patient needed heparin. So they couldn't be reversed. They bleed. Instead of letting them bleed to death, you stop the heparin, and the stent got blocked, acute thrombosis, we had to go back, do a sternotomy, and redo the whole operation. However, we published a big series of these, and virtually what it came out was the main limitation to this technique, when done in one go, was bleeding, and the need to combine anticoagulation with the benefit of not having bleeding because of the surgery. The whole thing's, however, evolved. We're starting to do access minimal invasion technique into what it was now, we thought, a minimal invasion with a maximal access, because as you can see, a big cut in the middle. And I won't spend any time on this. There are converted and there are not converted, and we heard it this morning. The trouble was that then, right in the sort of 2000 and something, the cardiology came out with a wonderful things, and they said, we now drug eluting stent with a 0% restenosis. I didn't make this up. The first paper actually showed 0% restenosis rate. So I guess people like me got terrified. And this is an analogy with our forefather. Most of you won't even know what this operation or what this X-ray shows. This is a plombage where you collapse the lung in order to treat TB. I've seen a few of these, actually, as a registrar. The fact is, in 1948, streptomycin came along, and that's it. No more of this surgery finished. So we thought that perhaps the same is going to happen to us. So why not be nice to the cardiology, right? Not least because this guy at the gatekeeper, the one who called in the shot. And if we don't want a life of misery, we have to talk to them. So here we are, hybrid again. Things have evolved. We had a situation where the mini thoracotomy was not relying simply on a sort of improvised small pediatric finocchietto, a coronary, as you can see in the middle slides, which is being literally snared by two snares in order to keep everything standing. We now had shunt, some sort of in the left-hand corner, then now you've got more instrument than you need. You know, it's like the patient is impaled from every possible corner. On top of that, we have gone from a situation of pretty basic image facility to these wonderful things. This is an hybrid theater. We got one in Bristol, I believe 1 or 2 or 3 in the country. And now you can do all sorts of fancy things and image what you're doing there and then. So you have a situation, as I showed you earlier this morning, of this patient, and what are you going to propose to do? Are you going to do a left internal mammary followed by an angioplasty on the right? Are you going to put 2 mammaries? Or are you going to put 2 stents? And that is what we've been discussing all morning. The fact is that the problem we had in the middle of 90s are still there. And what I mean for that? First of all, stents still get blocked. And that is the first thing. Although acutely not so many, because patients aspirin, and now there are even more strong antiplatelet agents. However, the problem which remains is here in the corner, which is restenosis. So when you get a situation like this, I always say when I do an operation, I like to be responsible for everything rather than having to share it with somebody else and we don't know whose fault of. Because, you know, this guy had a combined hybrid procedure, and now you can't figure out where I just crashed his car because of careless driving or because he had a cardiac-related event. So it's a very complicated issue when you get into that area. And, of course, the timing is the other enormous problem. Because when do you do it if you want to do it? Do you do all in one go? And then you got the problem of anticoagulation. Do you do the surgery before? Perhaps that's the best things, and then you do the intervention a few days later. But the implication of this is longer time in hospital to intervention and cost, escalation of cost. So what is my message? A few years ago, 5 years ago, I was asked to give exactly this talk at the European Society of Cardiology in Vienna, a full audience, 2,000 cardiology, all excited about this. And I concluded by saying, in those situations where the cardiology and the surgeon are not confident they can't treat the patient with other PTCI or surgery alone, they should use this. This statement means absolutely nothing. It's like a statement from a politician, actually, when you really look at it. But I was talking to cardiologists, so I was trying to be nice. As I was preparing this lecture, I thought it all back, and I said, but is anything like this actually happening? And if you think closely, some of this is actually already happening in the real world. At least this is what I do in my practice. There are situations in which I either because I can't find it, or either because like this is too small. So I may have done 2 or 3 grafts, and one I can't physically do it. So there is no harm in that case to say, maybe let's have an angioplasty in this main right coronary, or to say, as I usually do at the end of my operation notes, if this patient was to re-experience angina, since I wouldn't graft his right coronary, I would suggest an angioplasty intervention. But there is even a more common thing, if you think for a minute, which we are faced more and more every day of our practice, which is primary PCI. Now, if you look at this, the top picture is a right coronary. This is a patient who's come in, MI, occluded right coronary. The right coronary is being reopened. However, when they then look at the rest of the coronary, it's got a pretty tight LAD lesion and a circumflex lesion. So here, in the real world, this is already happening, because this patient will come back to you in a few weeks' time, maybe even in a week, maybe in a few months, and you have to operate, and you have to do effectively an hybrid procedure. And again, you run into a situation where you may do a wonderful operation yourself, you don't know what's going to happen to the stent. But in this context, at least, they dealt with a situation which was a really life-saving or emergency or trying to reduce the myocardial damage to this patient. So if I had to conclude to you and say what you should do, my advice is trying to do more arterial revascularization, trying to use more minimally invasive technique. I won't mention off pump because otherwise we may disagree. But most important of all, since nowadays mortality is not an issue anymore in cardiac surgery, trying to improve management. For example, we recently demonstrated the benefit of high thoracic epidural, which is a very controversial thing, and most anesthetists don't want to know about it. But the results in this randomized trial were so good, and you think we made them up. Things about strategy of blood conservation. A lot of this is going to be discussed tomorrow. Renal protection in an ever-increasing high-risk population. And blood sugar management, which is very much linked with outcome. So, but for most important of all, remember that the first thing is try not to do any harm. And what your patient want quality of life and life expectancy. So do the best operation for the patient, use the best conduit, use on pump, off pump, whatever you like. But remember that at the end of the day, the patient wants to have a good quality of life and he wants to live as long as possible. So I truly believe that proper full coronary vascularization is still the gold standard. Thank you.